So we thought we would use this opportunity to get some feedback and some insights in terms of the findings across all three of the studies that were presented. Wanted to hear from a mix of perspectives. So we have Bob Moore, as I said, the Chief Medical Officer of Partnership Health Plan, Jennifer Kent, the Director of the Department of Healthcare Services, Brad Gilbert, the CEO of the Inland Empire Health Plan, and Sarah Guia, the CEO of the California Pan-Ethnic Health Network. So we're just going to jump right in with some questions for them about the findings. And we're going to start with the place we started today, which was the findings that Dr. Bindman presented on quality trends in Medi-Cal managed care. And Jennifer, I know you and your colleagues pay very close attention to quality and access, and so I wanted to ask whether or not there were any surprises in the findings or anything in particular that was notable for you and your team as you think about managing the performance of the plans going forward.
Sure. So, I think, as you said, the department, and I've got Sarah Brooks and I've got McQMD folks scattered in the back as well. We do pay attention to the plan performance, not only from a quality perspective, but from a financial perspective. We have regular contract managers that are in kind of daily contact with the plans for a variety of different reasons. And I think we come to the oversight role treating all of our plans from an equal standing and basis, right? So we don't look at county organized health system versus local initiative versus commercial for-profit health plan from the standpoint that we have 24 contracting plans. They all have responsibility and over certain numbers of beneficiaries, and so we treat them from an equal standing equally. We have the same expectations for them, and so to the extent that plans are failing to meet quality performance metrics, you have seen an ongoing and steadily kind of increasing oversight and enforcement role that we have traditionally not had at the department. And I think, it predates my time as director, but certainly when I was at the department in previous jobs, and I know that you were at CHCF, and before Sarah even worked at the department, we didn't have the systems to even capture the data on the management of the plans. And so I like to look at studies like the one that you talked about this morning and kind of take a longer, more evolutionary look, which is a few years ago, we couldn't have even told you what data and performance measures would have looked like because we didn't even get that from the plans. So we've been, constantly evolving and modifying our systems over the years to both capture the data, but then to look at it from a trends perspective, to look at ways that we can, hold plans more accountable, and obviously the providers underneath those plans. But it has been a real kind of longitudinal effort on our part to certainly, expect more, drive towards a better goal, while still maintaining, appropriate safety net for, 10.5 million people.
Just to sort of follow up on that, so a couple of the bigger findings that Dr. Bindman discussed. One is over the 10-year period, there was improvement in about half the measures. So half the measures either didn't improve or we saw a decline. And then was this difference between the public plans, nonprofit plans, and the for-profit plans. Are those things known to the department? Are those things that you're managing to address? How do you view those findings?
I think we have, since we started the quarterly dashboards and putting those out for public consumption, there have been consistent plans at the top of those quality measures, and there have been plans that have been kind of consistently at the bottom. Sometimes there's a variety of explanations as to why. Sometimes it depends on the measure. Sometimes it depends on the kind of specifics. But I think there are expectations on both commercial and non-commercial plans. And if the plans are not performing, we have, things in place that we can do to hold them more accountable. So it wasn't necessarily surprising. I think that the procurement that we're doing starting next year is very much an interest in on our part to say, are we partnered with the people that are best suited for the job? We have not done a procurement in a really long time. That was something that I wanted to do when I started, and we're getting there. It takes a few years. But it's a big kind of consequential, important activity. We're taking it very seriously. But in my mind, it's all about confirming our business partners, and are they the best at what they do, and are they serving the beneficiaries the way that we want them to be served? And if we confirm that those partnerships are in fact the right ones, then the procurement will bear that out. And if the procurement comes to a place in which we choose different partners, then that also bears out in terms of what we're looking for. So I think we're aware that there are disparities in certain geographic areas of the state and between certain plans, and to the extent that we can mitigate that, we will. But I think it's also important to tell people we don't tell the plans how or who to contract with or who to pay and how to pay them, because if we are going to get down to the specifics of that, then we shouldn't have plans. We should just be doing it as a state. And so there's some balancing effect as a department that we have to strive for, in terms of we have expectations and we hold the plans accountable, but we don't go down to the micromanagement detail of telling them who and when and how to contract.
So next questions for our two plan
Chris,
representatives.
maybe if you don't mind, I'd like to follow up on the longitudinal theory here,
Sure,
which I really
sure,
like.
Brad.
I mean, if you really go back, I think I'm probably the longest tenured health plan employee, probably at least of this panel for sure. So if you think about what's happened over time, there was a lot of very good initial gains early on with managed care coming in, creating a structure, creating a network. And, that really sustained through, I would say, certainly the 2000s, flattened out a little bit, and then we really went backwards with 2014, 2015, 2016 because of the really large influx of new membership through the ACA that, wasn't necessarily as familiar with how to use a healthcare coverage. And so a lot of our scores were problematic for 14, not as much because they didn't have continuous enrollment, but certainly 15 and 16. I actually feel like we're maybe coming out of it a little bit now. But I'm a plan that's in the middle, and that really affected us because we grew by 350,000 members in 1 year. So being able to really understand who those members were, who those members are, who they were now, and how to actually make sure they access the care around preventive services. So I think, Jennifer's point that we've kind of learned together in terms of both our measurements, our reporting, and dealing with new populations. Certainly the CCI population, the ACA population really was different than plans at some level. So to me, that you've got to take that long look, and the 10 years that were picked, right in the middle of that was 14, 15, 16, and 17. So I think that's a piece of it.
Well, that's a good reminder to me that something I should have said at the outset, which is the reports that reflect the studies that we discussed today. Several of them will be online today following this briefing. The one from Dr. Bindman will not be, and that's in part because we knew the department is on the verge of releasing its the next round of HEDIS scores, or we think it is, and we wanted to incorporate that into Andy Bindman wanted to incorporate that into his report, and so we were waiting to finalize that until we could incorporate that data. But I think what you're saying sort of is another layer to the analysis that we should be looking at, which was, did we see improvements up until the ACA expansion, and then a drop as things got challenging and you incorporated new populations? So that would be a nuance certainly to explore a little further. Dr. Moore, I wonder if you could comment more generally on the opportunities, challenges of improving scores across the board. So as I sort of going back to this finding of half the scores, half of these HEDIS measures improved, and the other half didn't. That's obviously not for individual plans, and part of the reason that you and Dr. Gilbert are up here is because you're known in the Medi-Cal community as plans that are really investing in trying to address some of these issues, investing in building capacity within your systems. But I wonder if you could talk a little bit about how you approach the fact that you're trying to manage towards so many measures, trying to get quality across the board, and the challenges, the opportunities of doing so.
Sure. I think for partnership, we have 4 reporting regions. They're not counties, but they're reporting regions. Our Southeast, which is Yolo, Napa, and Solano County, or Southwest, which, although it includes Marin and Sonoma County, also includes Lake and Mendocino County. The Northwest, Humboldt and Del Norte, and Northeast, 5 counties in the northeastern corner of the state. And what we notice is that the delivery systems in those areas are not the same. In the 5 southern counties, we drill down to the county level for all of our quality metrics, and it's the 5 southern counties have a very different delivery system and consistently perform much better than the 9 northern counties. It happens that 2 of the 9 northerns were attached to the Southwest just by the way that it was set up. So they pulled down the Southwestern data. If Marin and Sonoma were by themselves, they would do a lot better. So it depends a lot upon the underlying populations. And the other factor is the delivery system. If a provider has a shortage of clinicians to actually provide the on-the-ground work, or if the clinicians they have were folks that couldn't get a job anywhere else, then it's not the same as say a San Francisco, where you have a lot of very highly qualified, dedicated physicians who are providing the actual frontline services. So I think that the delivery system makes a difference, and then to some extent the patient population makes a difference. We're treating all those regions the same, but we have dramatically different quality outcomes. In our Southeast region, it's listed over, as one of the higher performing county units or regional plan units, and then our Northeast and the others is way on the other side. And it's not the health plan, it really is the underlying factors. That's not to say that health plans don't have the ability to move the dial in any particular region, but that I think it shows that there are more overwhelming factors that are very dominant. And so from a health plan perspective, that's what we've noticed as we've worked towards improving quality.
And the differences in the delivery systems across the regions in which you're working, you mentioned both the size of the workforce that's available to serve the population, but also the quality of that workforce. I wonder if there are other elements of that delivery system differences across the regions that you would name as important factors. One of the things that, for example, one of the things that's been suggested is the level of integration across inpatient and outpatient, across primary, specialty, behavioral health. Do you see that as a factor, or are there other things you would sort of hold up as here are the 2 or 3 things that when we think about delivery system excellence and capacity and opportunities for improvement, here's what we look at?
So other factors, I think each of these has an impact, and I'd say that none of them is the magic bullet, with the one exception. The most powerful impact is an extremely strong leadership team at a particular delivery system. So if that has it's not again the magic bullet that'll take a population that's very challenging, and if you don't have enough providers, a strong leadership team is not enough. But if you have a strong leadership team on top of adequate providers, they can do an awful lot within that system. So that's one. The other ones that probably have an impact, but perhaps not quite as much. Our integration certainly has helped. If you integrate, a lot of our population has substance use disorder and depression, and anxiety. And especially the high cost patients and the ones that have lower outcomes, and so that. The ability to integrate behavioral health is a factor that helps, so it's probably responsible for a few percentage points as well. So.
Great.
So Chris, I mean, think about, when Bob's talking about a leadership structure and a leadership that brings the focus on quality, think about a solo practitioner or 2 docs in an office. They have 5 to 6 high school graduate medical assistants. There are no nurses in those clinics, in those physician offices anymore. There's no RNs or LVNs. There's an office manager that is often the wife and or husband if it's a female doctor. Then there are 4 to 5, maybe 6 MAs that are front office and back office. And so the ability to really organize that practice in a way that they can really focus on quality within their workflow, because that's the real key, is for a physician in the office to really be organized about preventive services needs, chronic illness needs. They've got to have it really driven within their workflow. And that is really hard. When you've seen one EHR, you've seen one EHR. How does our data get into that? The data we have about gaps in care, how do they integrate that into their systems so that when they're seeing that member, it's right in front of them and they can order the test or do the procedure or do whatever's necessary, and not just be focused on what walked in the door with a chief complaint. Walked in the door with my ankle hurts, my back hurts, I have a cold, I think I have the flu, and that becomes the focus if you don't have a workflow that allows you to look at that patient as a whole and really see that they need A, B, C, D, and E. Because if they're a diabetic, but they're in for bronchitis, if the focus is, do I need to give them an antibiotic or not? And it's not, I haven't tested their hemoglobin A1C in, 9 months, or I haven't done a foot exam, or I haven't done, I can go down the list, it's not going to work. So Bob's point about kind of the delivery system makes it more challenging. That's been one of our difficulties. We don't have a lot of FQHCs. We've got 2 big counties that, one's a little better than the other, but a lot of them are solo docs or small group docs. And so, we give them information about the gaps in care by their members for virtually everything, but if you can't incorporate that and integrate that into your workflow, it just doesn't work. And then I would add to Bob's point, behavioral health, if you're not understanding as a practitioner the role that behavioral health can play in not helping that member understand their illness or really deal with their illness because of their anxiety or depression, that's going to have a big impact as well. And so if you're not, if you don't have that, which is why I think health homes is actually going to be really helpful in a lot of these sites, because there's a behavioral health practitioner as part of the team, the ability to be able to recognize that so that you can spend additional time with that member to make sure that you're dealing not only with their underlying behavioral health condition, but all the other things they need done on the medical side. So to Bob's point, all these things play a factor, and the more barriers you have, it's going to be more difficult to get good scores.
Great, Sarah. I wanted to come back up to the sort of the overall findings and get your perspective as one of many strong consumer advocates we have in the state, and one that's thinking lots about health equity across the state, within regions, differences. What did you find interesting about the findings, and how might they be helpful to you?
Yeah, thank you. So first of all, thank you, Chris, and to the CHCF team for putting this on. Quality improvement is something that we've been looking at for a really long time. And for those of you here who don't know, CPEN is a multicultural health policy organization, and our focus is really looking at communities of color and the health of communities of color in California. And for over 25 years, around the early 2000s, or actually the mid-90s, we started looking at the demographic changes, and that communities of color had continued to be locked out of the healthcare system. And so the Affordable Care Act was a huge boon in terms of finally opening up the doors for communities to be able to even access care. And we had been actually monitoring Medi-Cal for a while in terms of the quality improvement. And so Dr. Bindman's findings for us were actually not that surprising. We had been looking at and sort of monitoring a consistent level of some plans really not meeting that 25th percentile, some plans doing a little bit better over time. For us, we really wanted to focus on who is in the Medi-Cal population. And, half of all of our births are, paid for by the state in Medi-Cal. Tremendous numbers of limited English proficient individuals. Folks who are facing a lot of different community factors that are impacting their health. And so when we think about the improvements to Medi-Cal and the things that we need to focus on, for us, this is also really about the values and the leadership that we're thinking about when we think about how we're caring for our communities. And so a big part of what we've been thinking about is how do we look at and tie the persistent racial and ethnic disparities that continue to impact a lot of communities, and how do we start to look at quality improvement and actually intersect with those. After many years of kind of working with DHCS, we finally got a quality report that was actually broken down by race, ethnicity, age, and language. And the differences are really important for us to think about. So for example, the ability, for when we look at gender, for example, males tend to have higher rates of not being able to control A1C. In age, younger mothers tend to be those who aren't getting the prenatal care. across the board, our African American communities are not getting the services and the care that they need. These are important nuances and details that I think we can't take a one-size-fits-all approach to quality improvement. We really have to look at, and I think Dr. Meideman talked about too, we need to look at better data to really assess where those disparities are, and how do we start to shape and inform our processes and protocols and practices to ensure that we're going to be working with maybe new care models, working with navigators, better integration of care services to ensure that we are going to affect and really impact those communities who are going to be served. So unfortunately, the findings were not surprising to us, but again, really the opportunity to start to uplift and talk more about quality improvement, and particularly as it's tied to racial and ethnic disparities, I think is long overdue. We've introduced legislation, we've kind of been working on this for the past few years to really start to look at what are opportunities, because we have also seen, in addition to this continuing progression around quality, is that we've also seen record profits with some plans as well, with not the corresponding improvement of quality. And so it's really time, I think, for us to delve deeper into this discussion.
Great, thank you. And Bob, maybe I could ask you just to sort of follow up on that before we move on to the next study, which is, as you think about, clearly you're thinking about the different, as you said, different regions and the different capabilities and leadership that you have to work with in trying to improve quality. When you overlay the issues about disparities within the Medi-Cal population, how do you think about addressing those? What tactics do you use to address the fact that African Americans, sort of across many measures, are receiving poorer quality of care than other Medi-Cal enrollees?
There are two ways to really work on a quality disparity. One is to focus an intervention on the group that has the worst outcome, and the other is to focus overall on that metric, and you hope that as they improve that the gap closes. And so that's important to say, because some gaps do, if you just focus on the quality overall, you naturally, the folks that were driving the lower quality are often in that group, and so you can make a difference. So the question really is, to what degree do you have to customize it? And I think if a disparity is due to something that is amenable to a customized approach, then that's a great way to go. So, for instance, a different way to outreach to people. If there's a language barrier, something that's more customized with language. If there's a particular transportation barrier that's associated, then something along those lines. But on the flip side is, we see that if you have if you make both if you make the disparity that is existing, if it stays the same and everyone improves, then you say, well, the disparity is still there, but there's improvement overall. So you actually have to drive more improvement when there's a disparity in that underlying group. What we find interestingly is that just in the partnership region, it's very different. Most of our groups are too small to be statistically significant, and so the groups that we are able to analyze for disparities, interestingly, for the most part, I would call it a reverse disparity in the sense that our worst outcomes are in men than women, and our worst outcomes are in our Caucasian population compared to all of our other populations, just about completely across the board. That hasn't always been the case, but more recently that has been. So for instance, one reason our vaccine rates are so great in our 5 southern region is because we have a large Hispanic population that doesn't mind vaccination. In the north, we have the same rate of vaccine refusal among the Caucasian population, north and south, but the Spanish-speaking population is protective, if you will. So that's an example. And so do we say, well, what's the appropriateness of doing a Caucasian-focused disparity intervention? It feels kind of odd. I think we just need to focus on the bigger issue in that particular case.
I don't know, maybe go after those anti-vaxxers. But, so the only thing I would say, I mean, to your point, Bob, I mean, and it's just, your point is, this overlays the whole thing now. I mean, the different cultural beliefs and, different issues about access overlay. We're going to do a doula program for African-American women. So we're going to start a doula program focused very specifically because of their very poor outcomes around, birth. And so I think there is a place where you do a very focused intervention on, for a specific issue, but you're right, you've got to decide between that and just trying to overall improve access and quality.
So I'm going to turn now to the first of Beth's 2 presentations, looking at the managed care purchasing and management practices in California and in other states, and the recommendations for the state, really, because some of the recommendations are things that the department can do, and some are things that the legislature would have a hand in doing. I think some of the things about simplification and audits and such may require some legislative changes. So Jennifer, again, starting with you, were there findings from that work? I know you're doing work in each of those areas, but sort of new rules, new ways of thinking about delegation. You've got you mentioned the procurement coming up and using that as an opportunity. What do you take away from that set of recommendations for the department?
Sure. So I think a couple of things. We're always mindful of what other states are doing when it comes to kind of managed care practices. Each state Medicaid program is really unique in and of itself. So sometimes it's a apples to kumquats comparison, and so we try to pick up things when we can. But sometimes if someone comes to us and says, "Well, the state of X is doing this," we're like, "Well, that's great. They have 2 plans and 500,000 Medicaid beneficiaries, and that's a little bit different than what we have in the state of California, where we have 24 plans and 10.5 million people in managed care." I think what we noted in that particular study or presentation is the need for, and I think we're working on this, is continued transparency in the quality scores and the other kinds of metrics that we are using both internal to the department, but sharing obviously with stakeholders. I think the feedback that we've already gotten from certain groups around, they took our base contracts and kind of made notes where they felt that we needed to change the terms of the contract on the procurement going forward. We've received some of that feedback, and then that's just being added to what we've already kind of identified for ourselves. I think when we look to other purchasers in the state, we do reach out to Cover California and CalPERS to say, are there interesting things that you're doing in your contracting approach that we could consider? Again, very, very different populations, right? CalPERS is not a Medicaid population, and Covered California actually has a very different composition than what is in Medicaid more traditionally. And so I think we try to kind of piece out the things that are of value to us and adapt them for our purposes. I think that the intention going forward in terms of developing a quality strategy and a kind of comprehensive vision for what it is that we're looking for. We, under the final rule, are required to have a comprehensive quality strategy, and so I think we're just on the cusp of getting ready to look at that again and say, what is it that we put an importance on? I think, my team hears me say this all the time, is that if everything's a priority, then nothing's a priority. We can't go to the plans and say, we want you to have exceptional scores in every single measure, every single quarter, every single year, with every single breakdown of your subpopulations, right? It's just physically not possible. And so I think what we have really tried to do is look at the things that matter most to us as a state in terms of who are we most acutely aware of that are maybe our highest cost users or our frequent flyers, and what is the comorbidities or the conditions that are driving that cost or driving that inappropriate utilization or driving those poor outcomes. And when you break those populations down, what are the metrics that we think we can effectively demonstrate, real progress with the plans? And so, to Brad's point, we are acutely aware of who those expensive populations are today. They have mental illness, they have substance use disorder, and they're either homeless or at risk of being homeless. So we know who they are. And you look at what we have done to try to impact that population in terms of the whole person care pilots, in terms of the health home initiative, the governor's proposal around value-based purchasing. We have a lot of interventions that we are in the process of trying, in addition to the other contractual oversight and regular quality programs that we have, because we know who is suffering the most in terms of poor outcomes. And these things just take time, unfortunately, and sometimes people's attention span is not in keeping with the length of time that it takes to effectuate a change. I always remind people that when I started as director in 2015, our dental program had recently been audited. We had really poor utilization for children, and it has been almost 5 years, and we are just seeing the utilization creep up to, I think we're at 47% overall, when we were down in the low 40s before. It's taken 5 years to move our percentage up 5%, and that's with rate changes and the Dental Transformation Initiative and the Proposition 56 funding and the changes to the administrative application for dental providers. And there was a lot of really kind of steady and consistent and focused work in that program to get the change that we have wanted to see for a while. And so I would just always caution people that in Medi-Cal, it's a lot longer than a legislative season. It's a lot longer than in a budget cycle. And so those of us that work in this program know that the quality that we are driving towards and the vision that we have is a 10, 15, 20-year set of interventions and progress, not just a single year or two.
Brad, I wonder, so one of the recommendations was this, was to shift from the compliance framework to a quality improvement framework or a continuous improvement framework. I'd be interested in your thoughts on that. Should rather than or in addition to this notion that there is a minimum that all plans are expected to meet, there is also an expectation that there be continuous improvement. You may not see it every year, but that the trend over a period of time is improvement, and so in that sense, each plan would be held to again, above the floor, above to a standard that reflects where it is now, and then, next year or within some time frame, we expect a little improvement each year.
Yeah, no, and I think one of the challenges is, Jennifer's point about our focus, which has to be on the individuals that are really a challenge and have multiple underlying illnesses that create just incredible complexity. But then on the flip side is the kids. How do we need to get the preventive services, the immunizations? We've got a measles outbreak, the well child visits and that. So it's this very different in terms of kind of strategies and very different in terms of the practitioners. Internal medicine, FP for the ones, Jennifer's talking about, peds, FP, some GP for kids. So, Chris, to your point, to me it's a combo. So, I think you do positive incentives for improvement and reaching certain thresholds. So, whether it's, continued upward trend, getting rid of the negative by 10% or whatever particular measure you use, to me you've got to put positive incentives on that. So, maybe use some of the MCO tax proceeds as an example.
I don't know what you're talking about.
Yeah, I know. For incentives. And then I think the other side, where if you've got plans that are really not performing, then I think sanctions are not unreasonable. But I would argue not just sanctions. I would say both sanctions and then pay for performance, which is what most of the plans use with their network is a positive pay for performance for both improvement and reaching certain thresholds. So actually, Beth, we had an objection to one of we don't believe that we agreed to a gate at 50th percentile for that, because that would take out the ability to reward for improvement below that. And you should. I mean, if I'm at the 30th percentile and I significantly improved to jump above that 50th, whether you sanction me or not, I should also get support for that improvement. And for our providers, generally we've used pay for performance. And so I think it's a combo. I also think it should be a finite, to your point, Jennifer, we can't do everything for everything, can't do everything for everybody. It's a finite set of measures, whether it's the 12 that we came up with through what I thought was actually a great process. We had a big debate. Maybe that's not enough, in terms of wanting to get better impact, but probably not the very long list that we have at the moment, in terms of what we're held accountable to. So, Chris, to me, it's a multifaceted, different ways to approach. You have to motivate for improvement, though. We were going to, after the state has come out with some of their ideas about holding us accountable, we had an internal discussion. We were like, draw the line. And then it was, no, you've got to, if people are willing to put the effort in to do the improvement, you've got to reward them for that on a year-over-year basis. So we've kept an improvement methodology for our pay performance, but we've raised our bars for the thresholds, you know, to really try to push our doctors to that higher level. So it's got to be, you know, you got to have multiple approaches, I think, to get everybody to move in the right direction. I'm a believer in positive incentives in general. Completely understand the state's need, though, if we're not performing at a really base level, you know, to hold us accountable to that.
But I mean, I think, you know, to Sarah's earlier point, this is where we as a department sit in the uncomfortable middle of the fence, right? Is we have some sides that say, you know, give the plans positive incentives, hold the carrot out. And then, you know, we are also very sensitive to some of the press attention and articles that came out last year around CEO compensation and plan profits. Because if we were, as a department, to say, fine, we'll put a big pool of money out there, and if you get it, you know, for quality incentives, that's great. The next story that gets written is, you know, fat cat CEO from Inland Empire Health Plan drives off a new Maserati.
Honda Accord.
And so I think that we try really hard to be mindful of, and again, we work in a state that is part of the administration with the Department of Finance, and so we also have to be mindful of the fact that we don't make unilateral decisions around financing in general. But I think that's been some of the struggle that we've had, and that's why I think we are really interested in how the value-based purchasing initiative goes using the Proposition 56 funding, because in some cases it is through managed care, but it is at the provider level, so the one that is, you know, turning the ship in terms of making that quality change because they have changed their practice, they have, you know, moved the provider, the patient, you know, outcomes, that the money goes straight to the provider as opposed to being held at the plan level, which we can't necessarily say goes to the provider that's doing the work that increases the quality. I mean, yes, they are all, you know, part of one ecosystem, but we're struggling to find that balance between not just letting the plan keep it at that highest level and maybe not have it be directed at the entities that are actually doing the work.
So great point. Let me do one quick counterpoint. Just specific to her thing? Okay.
So I just wanted to actually agree with Brad in many ways in the sense that, I mean, we had this stakeholder process. We brought people together. It was consumers, plans, providers. And we actually, I think, in many ways demonstrated that we can have a very civil and productive conversation, that there was a lot of cross-learning. We shared a lot of the concerns from the consumer side, because I do feel like that's the piece, too, that we really struggle to get across at times. Is I think it sometimes gets received as like, well, you know, you don't know, or, you know, we're trying. And I actually feel like there's a lot of information that could actually kind of lift up to the surface and really help to inform the process, a lot of potential solutions, because ultimately we are affecting consumers, right? We are trying to get to the patient. We need to understand what the perspectives are. And so I think overall we shared a value that we want to see plans overall improve, and that we know that this needs to happen because we've seen the long-term effects, that there hasn't been improvement. In some cases, there's been some decrease in the improvement. And so how can we continue to move the conversation forward with the variety of different factors that we have? We have some flexibility with dollars. We have some new funding mechanisms or some new models that we can look at. So I think the big takeaway for us is we've got the ability to kind of work in these different performance incentives, but we need to actually have the conversation. It needs to be really informed, and with all of us at the table who have a real stake in it in order to see some positive change move forward.
It was a great group. So a counterpoint. I got to do a counterpoint. So Jennifer, same exact issue in us in relationship to our IPAs, which is about 60% of our business, is that same exact thing. They're all for profit. So the idea of just, you know, having them get pay for performance money. So we actually mandated that, and I know, you know, you talked about how much do you want to push the plans specifically, that a significant percentage of the dollars in their plan had to go to the provider. So I mean, that's one way to think about that positive incentive. And yet, to your point, totally agree. If that dollar just creates a larger bottom line, that's not okay.
So Bob, we've jumped right into the third study and the second one that Beth described on financial incentives. I think there's an exciting new opportunity here, but before we get overly excited, I think it's important to reflect on where financial incentives sort of fit in the broader array and some of the limitations of financial incentives, where they work, where they don't work. And you've been involved in a pay performance program at the provider level. It's a bit different than a similar type program at the health plan level. But nevertheless, your experience and perspectives on this, I think, would be particularly valuable. So as you think about the state moving forward, if the state should move forward with this kind of value-based financial incentive, any advice from your experience you would give them in terms of either cautions or encouragement or both?
I think the main thing is just to keep in mind that any incentive or penalty is not a magic bullet, that it's one lever of improving quality, and it probably does improve quality for some people more than others. I think of about 7 different ways of improving sort of outcomes in a quality improvement realm, and in terms of strength of that, pay for performance is down around number 5 or so. There's policy helps a lot, and if there's a policy that every provider shall do something or they will lose their license, that's an example of a policy that changes behavior pretty dramatically. Social pressure, social influences are very strong, and that can help tremendously. Reframing is another one. We've had some good experience with that recently. Comparative data is helpful. And then sort of the least effective are just education, and if you apply purely to a person's altruism. You can combine altruism with other things, but pure altruism doesn't change quality too much. So pay for performance is one of, and ideally if you use multiple levers, then you can move things forward in a different direction.
So Jennifer, you talked about the value-based payment program you have for providers directed through the plans. In recent legislative testimony, I think it was actually Mary that talked about the department's interest in sometime in the near future a financial incentive program for plans, but weren't quite ready to take that on because had some other near-term intentions, simplifying the rate structure as one example. But I wondered if you could add to that and give us sort of a little insight into how far off you think something like that is from the department's perspective. Is that...
Well, I have to ask Mary. So I think, what Mary and certainly the whole kind of leadership team at the department are thinking through is we've got 2 big waivers that are coming due, both the 1915 Specialty Mental Health Services waiver as well as our 1115. You have heard us talk broadly about wanting to kind of standardize the benefits and get rid of some of the disparities that exist in the managed care models in California. I love finding out little factoids that each of the plans have buried in their contracts and rate structure. So like antipsychotics, for example, are carved out. I'm going to go on my rant for just a minute. Antipsychotics are carved out for every single plan in the Medicaid managed care model except for the health plan of San Mateo. So they pay and cover antipsychotics. Kaiser, we pay for specialty mental health services in Sacramento and Marin counties. But we don't have a direct contract for services in Marin County with Kaiser. So I'm not quite sure how that works. SynCal down in San Luis Obispo and Santa Barbara, everybody else has to send the glasses that are done for beneficiaries to the prisons, and they're done and fabricated through the Prison Industry Authority, except for SynCal. And so we have these like really tiny little nuts of inequality in the program, and what it does is it really complicates our rate structure. So we have 1,500, 1,600 rate cells that we develop every single year, which from a standpoint of just bandwidth and capacity cannot be sustained. It's not good for us. It's not good for the plans. It introduces a wide variation of treatment for beneficiaries as they move from county to county. And so what you've heard us talk about is both standardizing the benefits so that when you move from county to county as a beneficiary, you have a consistent package of benefits that's delivered by the plan. It's good from a rate setting standpoint because we will be looking towards going towards a regional rate setting as opposed to a plan by plan, county by county specific rate. I think what you also will see us wanting to do is by making it easier to do those kind of base underlying rate valuations, it will allow us to do more kind of solid work in terms of plan incentives because people will be treated equally across regions, and so therefore we can effectuate the outcomes that we are looking to do on a broader basis. I think that would also allow for us to think in terms of adding in lieu of services for the plans where we have heard, consistently the plans would like to be able to provide certain services that we currently don't allow them to include in their rates. But, we can't do that until we have kind of a standardized process of benefits as well as relying on their encounter data. So I think what you hear from us is, again, it's not a legislative cycle away, it's not a budget away, it's a kind of, we've seen the building blocks and we're in the process of kind of doing all those things such that probably in the next, I would say 5 years, you'll be hearing from us around, what are we doing? And this is, of course, that the economy doesn't crash. Because incentives are really hard to justify if, the Medi-Cal population goes up and the state's general fund goes down. But I would say, depending on all that rate work and contractual changes and the procurement and all the other kinds of underlying base activities that we're doing today, you would probably see us having a financial incentive discussion probably in the next 5 years.
So
but don't hold me to that.
I hope it's faster than that. And when you do the rate regions, I want to be with San Francisco. Okay, because we're right there to go. And then I'm going to disagree with Bob. I actually think financial incentives are higher for providers. We do our primary care physician pay for performance meetings, standing room only crowds. So I don't know if it's number one, Bob. I mean, I agree with you. I think there's other things. But I think, Prop 56 has really helped, I think, in terms of trying to stabilize the financial status of our physicians, for Medi-Cal in general. But they're very concerned. We have a $60 million primary care physician pay for performance program. So they're very concerned and really want to do their best and just have the barriers we've talked about in terms of data transfer and workflow. But I do think that, financial incentives can drive behavior in the medical system. So I'd probably put it number 3, maybe 2, versus 5. I do think it makes a difference. And remember, San Francisco region for the Inland Empire.
So it sounds like one of the questions for us is how do we accelerate the building of those blocks? Because it seems like something that is, as we say, other states are doing it, and the time seems right. So we are 25 minutes from wrapping up, so we've got plenty of time for questions and answers. So do we have Crystal and Karen with mics? So if you have a question, please raise your hand, and we'll start over here.
My name is Jeff, an advocate, interested in seeing about single payer, but also more interested in, I've heard the population that you're describing, and also dealing with all of your studies, what is the highest percentile that any medical service, Medicare, provider has ever reached?
So a percentile is the percentage of people that perform below a certain number, okay? So 100% of providers perform below the 100th percentile, okay? 50% of providers perform below the 50th percentile. So 50th percentile is average. It's like if you were in college, that'd be a B, okay? It's not 50% on a test, it's a B. And so that means that half the plans across the country do less well and on that particular measure and half do better. Now, interestingly, if everyone gets better, then the overall score will get better, but the 50th percentile, still half the plans will do less well and half the plans will do better than that 50th percentile, because by definition it's the point at which half are below and half are above. And that's an important consideration, because one of the graphs from the first presentation showed the percentage of measures that were below the 25th percentile, and it never was 25%. It should have been always 25%, or maybe if it was off, it's because they were using the prior year's measures, and if they were improving, then it might be a little less than 25 percentile. So I don't think, to be honest, NCQA, when I look at that, their methodology for 25th percentile is not trustworthy. I'll just throw that out there because of that graph, and it's something we've noticed over time.
Well, I think the graph was showing the number of California measures that fall below the 25th national percentile.
No, it was nationally. That was the interesting. Yeah.
I think so. So actually, this is a good reminder that at this juncture, I wanted to invite Dr. Bindman and Beth Waldman up to the stage here to join us for this part, so you can ask your questions of the panelists or of either of our speakers. Only one way to come up. We have a question over here.
Hi, my name is Jeff Berg from UC Davis Medical Center, and I just wanted to point out and kind of had a question about how the population that was pointed out at the beginning, how it's basically tripled over 10 years from when these managed Medi-Cal programs started. To going to over 10 million beneficiaries now, and seeing how a lot of those rates have declined, and a lot of those have to do with access to care and child care and maternity. So obviously, especially with the ones that are really close over time, maybe have declined a little bit, the total numbers of beneficiaries being touched and improved upon is probably significant. So I just wanted to hear your take on the expanding population of these managed Medi-Cal beneficiaries has had on the decline of these rates.
You know, I would say it's not only been in the last 10 years the Affordable Care Act and the enrollment of the single childless adults, but prior to the ACA, we had mandatorily enrolled all of the seniors and persons with disabilities into managed care. So in the 90s up until 2011 was when SPDs got mandatorily enrolled. Essentially, managed care in California was moms and pregnant moms and kids, which is kind of the easiest population to manage from a managed care perspective. And then in 2011, we mandatorily enrolled the seniors and persons with disabilities, which was a completely different and far more challenging population for the managed care plans, with the exception of the county organized health systems, because they already had the SPDs mandatorily enrolled. And so I think you saw some of the data and quality measures certainly dip as the plans absorbed that population. I know that it took probably a good 2 years before we saw the ER utilization for SPDs finally start to kind of go down as plans got better management of that population, got prescription drugs, under better control, and certainly introduce them to primary care as opposed to using ERs. And so some of those quality measures have just changed as we have enrolled large, significant populations. You also saw the Healthy Families kids come into the Medi-Cal program in 2013 in advance of the Affordable Care Act. And so we've had big, huge changes in our just population composition over the last 10 years, which has been somewhat healthy, like the Healthy Family children, but then also the duals for the CCI counties. And so each kind of big population, you have also seen, as Brad would say, an absorption by the plan, and then there's a dip, and then they have to kind of get a handle on that population in terms of either different providers under contract or different expectations for what the work is being done with those populations, and then you see the quality kind of then slowly kind of change over time. And so that's, I think, what we have seen in terms of the data.
Andy, I wonder if I could get you to comment. You may need to. Do you have your own microphone? Yeah, great. On, I guess, the 2 points that have come up. First, Bob's observation around the national Medicaid HEDIS percentiles and the percent of quality scores that fell below the 25th percentile. That was one. And then the other was whether in your analysis of the data you looked at this issue of the ACA expansion issue and whether that accounted for, or is that some future work to be done?
Yeah, so Yeah, in terms of the graphic around the 25th percentile and the percentage of our measures that was relative to a national standard. So when you're seeing that bar graph go up, that means more and more of our measures as a percentage have gone up relative to that 25th percentile, that we have more below the 25th percentile over time. Even if the 25th percentile nationally went up, went down, whatever, relative to the national, we were losing ground. And what's the way you can see that most clearly, because there's a change in the number of plans and so forth, is that percentage along the x-axis that shows the percentage of measures that have gotten worse over time. So 2017 does look like it might be improving some. We'll have to see what goes on with 2018 with regard to that. This issue about, I think it's an interesting idea. There's clearly a learning curve when you're bringing new people in and plans they have to get used to and so forth that have clearly stressed the system. The ACA is a big example where there was a very sizable population increase. It doesn't seem clear in the data, though, that that's kind of what's going on. I mean, basically, it was flat before, it's flat after. We're not seeing this dramatic change that, wow, we were killing it before the ACA, and all of a sudden, we lost some ground here. And I think I haven't mapped out these other specific policies around bringing in healthy families or the SPD change. Although it is striking, I mean, I think, it seems on the surface like the TANF program, women and children, might be simpler, but interestingly, that's where we're actually having the biggest fall in our performance. And so maybe it's because our attention is diverted to SPDs or other things, but we definitely have lost sight of something that is a very important priority, women and children, which are, as others have pointed out, half of the children in the state are covered by the Medi-Cal program. Access to primary care for children has clearly deteriorated over time. While clearly more children may have come in to the ACA, post-ACA, that's not the main population that was affected by that policy. So I think there's something else going on.
Thank you. Oh. Josh Morgan with SAS. Thank you for this great conversation. My ultimate question is relating to ways that we look at kind of both cost and human outcomes, and how much we're looking at it in kind of a health silo versus a broader perspective. As we're talking about financial incentives, looking at state budgets, hopefully being well for a while, number of Medicaid beneficiaries, improving access to coverage, lots of conversations around cost containment. Then there's ways of framing it more in terms of cost effectiveness or value. When we look at things like Dr. Gilbert, you talked about health homes, broadening out the impact of care beyond just health care. How much of this quality conversation and incentive conversation should we be really reframing out of a cost containment and purely healthcare perspective into something a bit broader across all of our spectrums, from health homes to like whole person care as examples, or health plans paying for housing that have other impacts? We know they all intersect with one another.
Well, we're in the housing business at IEHP, and Jennifer's point that was important was before, and I think it's very fair, before you can start to talk about, in lieu of services or, other ways of thinking about financing, you got to get the basic house in order. I can't disagree with that. But part of the Manat report, which was sort of a precursor to some of this other activity, was specifically around encouraging plans to invest in those social determinant of health types of activities, to think about ways of helping our members that are very different than traditional delivery care. So doulas for African American women to try and get them, focused into the prenatal care and have good birth outcomes. Housing for our individuals that are homeless and high utilizers or in long-term care facilities and shouldn't be there. There's no reason for them to be there and costing at the level they're costing now. So I think you're absolutely right. I think we're all thinking about that. But to get it on the rate side is going to take, that work to get the rates kind of stabilized and standardized, and then you figure out how to overlay on top of that. But your point's totally well taken. We've been talking predominantly about delivery in a physician office, which is one piece of a member's issues. You've got the whole behavioral health and SUD piece, and then beyond that, you've got, homelessness, you've got other issues, food that affect people and probably have more impact on their health than anything we can do. Homelessness, primary care physician doesn't really make much of a difference at all. So, point well taken.
I would agree with that. I think we're in a very interesting time where I think you are seeing a lot more health systems or health plans really look at what effect can we have. And I don't think anybody has the answers on our advisory committee. We couldn't necessarily identify what's that one measure that we would look at to sort of see what the social determinants of health would be, or like what's that factor we would monitor. I think as we go forward, I think just making sure that the physicians and we all understand what those impacts are, that there's been a lot of work done, for example, in housing, and this was like 10 or 20 years ago, where you had health systems partnering with tenants' rights organizations to keep people in healthy homes, because that was going to affect whether or not they were going to go to the ER. So I think short of having to have health systems start to actually become tenants, or having to become landlords, I think that there are a variety of different models that we could look at, or investments that could be made. I know there's community benefit programs that a lot of systems have as well. And so I think you're right, like we need to make sure that that is a part of the conversation as we go forward, because those are the factors that really do impact people's lives and health. And the healthcare system needs to, we need to keep that conversation going about like what is that right mix in order for them to also be an influencer and also a participant or partner in that.
So Sarah, can I ask you just to build on that a little bit? One of the things that your organization is involved in is thinking about how to bring together the delivery system transformation lens and the health equity lens, working with Families USA and really taking advantage of the energy here in California around both of those streams and bringing them together. And how do you think about, in that work, how do you think about the delivery system in a classic sense within the broader in terms of moving forward health equity?
Yeah. So one of the things we started to do is look across, I think, so as Chris is saying, sort of building on this momentum. We've done California continues, I think, to be a leader. There's a lot of states who are doing some really innovative things as well. So we want to look at what are the investments that California has been making over the past few years, because they've been a little bit fragmented. A lot of different things here. There's the CATCHY program over here. There's the whole person care pilot, right? So there's been a lot of different efforts. So one of the things that we're looking across and doing an assessment of all of those different efforts and actually really determining, is health equity, has racial and ethnic disparities or language disparities or gender disparities been a key factor in any of these? And in what ways have they? Has consumer involvement or engagement been a part of these different factors? And I think what we want to try to identify is, where are those places where it's almost there? It is there or it's almost there, and how could we really build upon, improve, or scale up those particular models? And where is it not at all? And where we might need to start to kind of reach out to those particular systems or those initiatives to really get those efforts moving and building upon what's also happening in other states. So we're working with Families USA too, which is more of a national organization, to look at what have the other states been doing that are more aligned with our healthcare system model, because a lot of states out there are not, managed care like we are. But what are some of the ways that we could learn from other organizations as well? As we look at the potential waivers that are coming up, I think we want to both, again, build on what has been working, but also identify how can we really factor in the demographic changes and needs that California specifically has, particularly in thinking that, the 14 million lives that are covered in the Medi-Cal program, about 80% of those are communities of color. A large majority are limited English proficient. That's where the nation is going. How can we be a leader for other states, and how can we really be an influencer at the federal level to also look at how equity and quality can better be aligned for the improvement of overall health?
Did you just say the federal level?
Thinking positively.
Chris, one thing we haven't talked about at all, it's very boring, but it's incredibly important, is data transfer. Use of data, whether it's us getting better and counter data to the state, or it's a health information exchange type model that brings data into physician EHRs. I mean, there's a lot of work that needs to be done in that area around the ability of data to transfer from the plan to the provider, from the provider to the plan, from the plan to the state. I mean, that's still a really, not totally mature area that is pretty critical to quality, quality drive and quality measurement. Just a thought.
Actually, I love that you just said that. I'm Ninik Vu with California Primary Care Association, and one of our biggest initiatives now is to try to figure out how to improve our encounter data submission to the plans. And we're exploring just about every possible solution. But do you guys have best practices in how plans engage and support health centers or providers in getting the data that they need?
So just a crazy thought. You bill PPS for every single encounter that you have in a federally qualified health center. That should be absolutely encounter data to the plan. So, Bob, you...
With one exception, if there's an added service above a visit code, then there's no incentive to add those. So, for instance, the developmental screening codes, if you add that code, you're doing it out of goodwill towards the health plan to be able to report it up to the state or some other reason rather than because once you've built an encounter, all the other little codes that the state wants and the feds want and we want, there's not an incentive. So that's a tricky part that's the flip side of the PPS system.
So do you see, Bob, I mean, really, to me, that's programming your EHR. So if you do a well-child visit at age 1, every single pertinent code, if you're doing a full well-child, every single, developmental guidance code, BMI assessment, I mean, they should just be those codes. You just need to build those into your EHR. So for that visit, those codes are produced. But my point about the PPS is you know every visit you have. You know it. But Bob's point is you've got to make sure those visits incorporate all of the codes, that you've done.
So we've talked a lot about some pretty sobering data and provide some recommendations for a path forward. I wanted to end on with a sort of positive note out of all the sobering challenges, and it'll take time. And I wonder if you could each highlight something in your own work, either something your organization is doing or something you've seen out in the world that particularly excites you, gives you hope of that the challenge that we described here in terms of improving quality in a broader sense, particularly around children and mothers, that we won't be here in 5 years looking at data and seeing the same picture. What are some things that you're doing or investments that you're making or initiatives that you're leading that give you, that you can offer sort of a ray of hope to those of us who are listening today?
I get to start? Okay. So I think a couple of people have brought up this issue of the workforce and access, particularly, and for us it impacts us in rural areas. So one of the things that we've really begun to focus on is contributing to the, and this isn't in lieu of, but it's not actually in lieu of, but it's totally, we have to use our reserves to fund it, but it is actually provider recruitment support. So for the organizations that are trying to recruit from outside of our service area. The unfortunate thing is other health plans have picked up on this. So now that it was good if everyone does that, then there's incentive to people to move between one plan and another outside of different service areas. But I think that's really critical because if you look at those measures that are going down since 2013, and actually the new measures that DHCS is proposing to add on now, many of them are really most strongly influenced by access. So I think that's key. And then there's another, and we support we've supported starting up a couple of residencies in our area with just a little bit of seed money, and those took off, and they both are starting their first classes this summer. So that's a big upstream effect. But if you can get good providers trained and stay in the area, then that helps as well. So those are some of the workforce areas.
Great, thank you. Thank you.
Yeah, so our Proposition 56 loan repayment applications, we crashed the system over the weekend. And that's good because basically a bunch of doctors and dentists procrastinate. And so they were trying to apply by the Friday deadline, and they basically brought the whole application system down. But we have heard that we have at least 1,400 applications for what is around 125 slots on the physician side, 20 to 25 on the dental side. It's up to $300,000 in loan repayment for a 5-year commitment to the Medi-Cal program. A third of your population or your patient base has to be Medi-Cal, agnostic to specialty type or geographic area. So we have a lot of expectations that this will change the trajectory of physicians when they leave their residency or finish dental school, that instead of making a financial decision around where they want to practice or who they want to see because of their loans and their outstanding debt, that we will take that away from them in terms of that consideration and certainly change a lot of the trajectory of people's professional areas in practicing in Medi-Cal. And then the other thing I think that we're really proud of right now is the work that we've been doing around the opioid grants. That has been coming to the states specifically for opioids, but we're using it to build larger delivery systems for substance use treatment, and so I think that's a pretty exciting area that we're in right now.
So before we go to Brad, just a reminder, evaluations before you leave, if you could complete those and turn them in, and I'll give maybe 30 seconds to a minute each.
So I don't know how many people were able to see the results of our behavioral health integration pilot, but we had 33 sites at a whole variety of different types of delivery systems, and we got improved blood pressure, improved BMI, improved hemoglobin A1C, decreased depression scores, so real positive quality impacts from delivering primary care and behavioral health together. And that, I think, is a really good precursor to the health homes. So we have 4,000 members already enrolled in our health homes program. So I think there's real opportunities there.
So at CPEN, I talked about the project that we're doing, and we're hopeful to bring together providers and plans to actually create some recommendations that we could deliver to the state to think about how do we really marry together the reduction of racial and ethnic disparities with quality improvement.
Something that you're seeing around the country?
Well, I just want to say, I think that we work with states across the country, and again, California is completely its own unique animal, I think it's state. I remember hearing when I first started consulting what the Medi-Cal budget was in California at the time was like 23. It's a lot more now, but that was the whole size of the Massachusetts budget, just to give you sort of a sense of how big that program is. And so, I think you all have this incredibly devoted workforce, whether it be at the state or at the health plans, at the provider level or at the consumer level, which is very active and engaged, and you don't see that in every state, and I think that's something to be proud of, and not necessarily always fun to have the sort of discourse back and forth, but really, I think in the end helps to improve the program over time.
So Andy, something positive in your work?
Yeah, I'll just put on my other day hat, which is I'm a primary care physician at San Francisco General, Zuckerberg San Francisco General Hospital, and one of the things that I see that's very powerful in our environment that gets at something raised earlier that I think is really something to think about building upon across the state is we're very fortunate to be able to leverage not only the resources of the health plan, which has been a tremendous investment in our growing an e-referral system within our provider network, but also the larger Department of Public Health to get at some of the issues related to social determinants of health. And I have found that the way that we've been able to use our local data and to be able to think and leverage those resources, I think is something very special about how the health plan can work in a cooperative way with the health department and the practitioners that has really made my ability to be a primary care physician in that setting easier and better and more connected feeling. So I think it's a very hopeful model in my own local environment, and something that I think provides perhaps a model to think about how it could be leveraged across the state. So anyway,
Great,
thank you.
Thank you, and thank you all. Please join me in thanking our panelists and our speakers. And thank you all for joining us today. Have a good afternoon.